Okay, everyone, good evening and welcome to the North American Thrombosis Forum's Blood Clot Support Group this evening. We have a very special support group for you in honor of World Thrombosis Day, and we are focusing on menopause and blood clots and just, what the risks are and what women at that stage in their life need to be aware of. So thank you guys all so much for joining us. I will go ahead and let our esteemed panel of hosts introduce themselves this evening, and then we are going to have a quick video from a patient who experienced blood clots actually at different points throughout her life, and then we'll open it up to a discussion. Many of you did submit questions in advance, so we'll be sure to address those. Thank you so much. And then the only other thing that I wanted to mention was that we are going to put a link to a survey in the chat box. So if you could, at the very end of the program, so if you could just take a few minutes, not even minutes, seconds to fill that out before you log off, that would be terrific. So I would also like to thank WomenHeart and the Foundation for Women and Girls with Blood Disorders. They've partnered with us on this, and so it's great to have them there this evening and some members of their audience as well. And I will go ahead and turn it over to Dr. Bacon to get us started with introductions.
Thank you. My name is Janice Bacon. I'm an OBGYN and a subspecialist in pediatric and adolescent gynecology in Columbia, South Carolina. I'm very pleased to be active with the Foundation for Women and Girls with Blood Disorders and have been privileged to serve on the board and the educational committee. And I'm very excited to participate in the webinar tonight.
All right, thank you. And Margot.
Yes, hi everyone. I'm Margot Manisian. I'm a cardiovascular prevention scientist, and I'm a clinical lipid specialist. And most importantly, I'm first and foremost a nurse. I'm an advanced practice nurse in cardiology. I have been for about 20 years. And within my role there at Cedars-Sinai in Los Angeles, I help women get on those vital medications that they need, in particular, our cardiovascular women who are dealing with either trying to prevent heart attacks and strokes, or they're trying to prevent a second heart attack or stroke or a blood clot. So I'm very excited here today to be visiting with all of you. This is a passionate topic for me. My best friend is the past Menopause Society president, Dr. Cassandra Schufelt, and we have lots of discussions in this topic. And so I am excited to be your focused cardiovascular prevention person for the evening. So nice to meet everyone online.
Terrific. Thanks, Margot. And Jean.
Hi, I'm Jean Connors. I'm an adult hematologist at Brigham and Women's Hospital, Dana-Farber Cancer Institute, and Harvard Medical School. And I treat patients with blood clots, particularly women. I run clinical trials in treatments and prevention of blood clots, and I am a steering committee member for World Thrombosis Day out of ISTH. And so we're delighted that we can recognize World Thrombosis Day with a strong emphasis on women and risks across the lifespan, particularly menopause today. I think that there is so much we need to learn and so much the public needs to know about just what we do know and what we don't know about various aspects of menopause and its risks and benefits to women's health. So looking forward to the discussion.
Terrific. Thank you all for being here. So now if technology will allow me, I'm going to play a video from a patient, Christine, who, as I mentioned, has had both DVT, PE, and a heart attack. So she is unfortunately very familiar with the different types of thrombosis at different stages in her life. So I will go ahead and cue that up. All right. Can you guys see that? Now, hopefully you'll be able to hear it.
Hi, my name is Christine Van Bloom. I live in Frederick, Maryland, and I have had DVTs and PEs. Back in 2013, I was on the Nuva ring, which was hormonal birth control, and the DVT.
All right. So hold on just a minute. Gonna cue this up again for you guys. See if I can get the audio to work and backtrack a little bit. My apologies. All right, let's try.
Which is just a genetic blood clotting disorder. And apparently, I'm no doctor. I think it's fairly common. Finding out I had that changed a lot of things for me, truthfully, because I never knew. And I had been on hormonal birth control since I was 19. So finding out about that enabled me to kind of take charge of what I was doing with my health there. Then in 2020, just as I was starting menopause, I suffered a widowmaker heart attack. I had a blood clot, 100% blockage in my LAD. And that was not great, and it felt awful, and it was a really challenging time to go through. Now, I'm a super lucky girl because I have terrific doctors and I have the most incredible support system in place. But even so, even with that, my family doesn't always understand what it is that I'm dealing with because they don't have these issues. Thank goodness. I'm so happy they don't. But finding support as you're going through the DVT or the PE process, or after a heart attack, even, is so vital. It's so important because middle age can feel lonely as it is. And when you start having major health issues, you want to get through them. And I think you want to get through in the most positive way that you can. I'm a super gung ho, let's do it, I'm going to be fine kind of gal. But that support was tricky to find after all of this. And having my blood clot that caused the heart attack in 2020, cardiac rehab is a big part of that, but 2020 things were a little different. So the camaraderie and the support that usually comes from that wasn't part of my recovery there. So it's become really important to me to lend support to other women that are going through it from a completely non-medical standpoint, because I've been through it. And in sharing my story with women my age, they have gone and talked to their own doctors. Immediately following my heart attack, I started posting some things online because I just thought it would be helpful. And I've always been like, here's my world, like it or not. So I posted what it was like to go through that. And 3 women reached out to me in very short order. I mean, within a day or two. And I advised every single one of them to reach out directly to their doctors as soon as they could. And all 3 ended up with high blood pressure and on high blood pressure meds. So support, finding really qualified, good support, super vital if you're going through this.
Okay, so I thought that was, I don't know if Christina is joining us this evening, but a huge shout out and thank you to her if she is able to join us. And thank you so much for, being willing to share your story with us. Unfortunately, I think it's a story that a lot of the attendees on this call can probably relate to. So I wanted to dig into some of the questions that we got submitted. And also feel free to put questions in the chat or in the Q&A. I'll be monitoring those throughout the evening, the next 45 minutes or so. We'll try to get to as many of those as we can. I thought just to kind of start though, and this is a personal question as much as one that was submitted, but can we just start by defining what menopause is? So I feel like I'm 42 years old and I should know this definition as a woman, but I don't. And so what is the clinical definition of menopause?
So I'll take that answer first. And then clinically, menopause is really a retrospective diagnosis, and it's 1 year without menses. And then I will sort of add to that and say in the appropriate setting, because we do know there can be some younger women that have premature menopause because of genetic abnormalities, or who end up with premature surgical menopause because of other medical conditions. But in the United States, the average age that women go through natural menopause is usually between 51 and 52 years old. Before menses stop, we often have a number of years of some chaotic ovarian hormone production that we call perimenopause. So at 42, you could be experiencing some of those symptoms. We don't currently have a blood test that will predict when women go through menopause. Mm-hmm. And our age at menopause is not quite as reliably associated with our family history as the age of the onset of our periods.
Oh, interesting. Okay. Well, thank you so much. That was very helpful. And Jean, Margot, anything to add there?
I would love to, that was an important point that Dr. Bacon just mentioned in regards to those women that have menopause early. That early onset menopause is actually an increased risk of cardiovascular disease and is considered a risk enhancing factor. So if you go into menopause prematurely, that we make note of. So that's something that you would definitely want to let your doctor know about. And not just your OB or your primary doctor, but maybe getting a second look from a cardiologist.
What's defined as early? Is that like 50? Is that like 42? Like what is it more highly correlated to the earlier the menopause starts, or?
That's a good question. Dr. Bacon, did you want to?
Well, I was going to say, although sometimes the terms that we use in medicine and the terms that the lay population uses can be somewhat different. We may think that between 40 and 45 years of age might be early menopause, and before 40 may be somewhat premature. So I think that those are two important categories, and I like it that patients are becoming more interested in reading about these categories so they can see what fits them.
I'm gonna throw out a third category that I tend to deal with at the Dana-Farber, which is young women who undergo chemotherapy treatments, stem cell transplant, total body radiation, and I've seen people in their 20s have what we don't call it menopause, we call it premature ovarian failure. But we also then need to address, to Margot's point, the long-term health effects of lack of estrogen. So, and I tend to see these patients when there's a conflict or a concern about use of exogenous estrogens and hormone therapy.
Mm-hmm. Yeah, and it's defined as a woman who goes into menopause, whether that's surgically. So that's something that, that Dr. Connors just mentioned. They're going through some type of a medical procedure, or they're having something that's happening to them medically that is, placing them into menopause, or it's happening naturally, but it's when menses has stopped and they're under the age of 40.
All right. Very helpful. Thank you. So the far and away, the biggest question we got, and they're already coming in on the chat too, is about estrogen and hormone replacement therapy and the safety and efficacy of those, in general, but also specific to this population. So women that, largely have a history of blood clots, whether that be a DVT or heart attack, stroke. So I would like to kind of dive into, I guess, the different options that are available to women, but also talk about kind of the safety and what we know about HRT and specifically estrogen. If somebody wanted to kind of walk us through the different types that are available to women today.
I think that it would be important to look at these women regarding their events that cause menopause and their age, because I know that you all can speak much more eloquently than I can to all of the risk factors that increase for all of us with aging and increase our risk for blood clotting disorders. But the younger patients, even thinking of women with genetics problems like Turner syndrome, who we expect to go through premature menopause, the way we treat that disorder is going to be different than we treat the disorder in women as they are older. So I think that if we're going to talk first about our patient Christine and the things that happened to her, that might be more pertinent for many of the members of the audience than talking about some of the youngest group that have had premature ovarian insufficiency from malignancy treatment.
That sounds great. Absolutely.
Okay. Well, and what we want to think about is the variety of things available. So for some women with blood clotting risk, they may feel that any type of hormone therapy would be too risky for them. And that might also include women who are undergoing chemotherapy themselves for things such as breast cancer or other surgical disorders, but they may feel that they would like to explore non-hormonal therapies. And we thankfully have more choices available, particularly a new product that is a kisspeptin receptor binding medication, which is better than things that we had before, which are things like gabapentin and other neurotransmitter receptor agents. So that's one thing if we want to look at that in one direction. Next, it would be those women who are looking for specific symptom relief, for example, vaginal dryness or painful intercourse. And for those women, and really all of the women as we age, using a vaginal estrogen puts so little, if any, systemic hormone levels in our bloodstream that can be considered for all women. And even though the caveat is that for women that are being treated for what may be an estrogen-dependent neoplasm, they should discuss the use of even vaginal preparations with their oncologist. Outside of that, I think we feel confident that vaginal treatments such as cream or tablets or even a ring that can stay in for 3 months might be applicable to the great majority of women. Beyond that, we start to move into systemic hormone therapies. And if the uterus is present, it's really important that we balance estrogen and progesterone. We could talk about those in 2 different categories, but in estrogen, we want to look at systemic therapy via transdermal methods, such as a patch or an oral therapy. And certainly for women with clotting abnormalities, looking at something transdermal would be really important. And even combination therapy can come in a transdermal preparation. I could continue to elaborate, but I don't want to take up more than my share of the time here. So when I see somebody doing this, I will certainly stop. But maybe that will get us to introduce the topic. I'll put it that way.
Yeah, no,
Absolutely.
I'm just going to riff off something that you said that resonates with our patient's story, right? Because she was on the Nuva ring, right? Which is, I think, a
Yes.
different type of estrogen containing cervical vaginal ring. And I think that age and hormone type are the key factors in development of venous thrombosis, right? So the Nuva ring is definitely associated with increased risk of thrombosis, just like combination estrogen, progestin, oral contraceptives, the pills that are used for oral contraceptive purposes. And some people think because it's acting locally, it may not have an effect like topical vaginal estrogen, but it does have, it reaches systemic levels. And I have to say, I don't know, Janice, again, you may deal with a younger population, but that perimenopause time frame that you were discussing, I see so many women who are in their early 40s, be careful, Catherine, no, or mid 40s, and they have heavy menstrual bleeding because of the hormonal irregularity. And so to control that, they get put on combination estrogen, progesterone, oral contraceptives. And I am biased by who I see, but then I see these women when they have a pulmonary embolus. So, you know, I think that transition period, in my mind, is somewhat a little more problematic than your patient's in menopause and they haven't had a period for 9 months and they have horrific hot flashes, and what can you do? So I don't know, Janice, what your thoughts are about what can we do for those women in sort of that perimenopause stage with hormones swinging all around, heavy menstrual bleeding.
Yeah, that's a very important point, because the composition in menopausal estrogen therapy is usually estradiol, similar to what the ovary produces. But the estrogen most commonly employed in contraceptive regimens is ethinyl estradiol. And the progesterones differ as well, such that the ones in contraception may be more thrombogenic than micronized progesterone, for example. So that's really important. I think one of the things that is essential is for us as providers to work with our patients to make sure that their problem lists are up to date and that we have taken a thorough history regarding all of the issues in perimenopause, with specific reference to risk for clotting disorders and cardiovascular disease and things like that. And I think sometimes when we focus on things, we're talking about symptom relief, and we need to focus on the long term as much as the short term. For women that have no known risk factors, then thinking about a contraceptive method is a great idea. And for those women, that can be continued up to age 55. But for our patients, such as Christine, that have known risk factors, we must be much more careful and not go right to a contraceptive regimen. The thing that comes to mind for me, first of all, would be using a progestin-containing intrauterine device, because that is something that will treat the uterus and balance out any other therapy we give. And then from that point on, we can give a small dose of menopausal estradiol if needed for symptoms. And thankfully, the patch comes in such a wide range of dosing that we have a good choice of things to go with.
Yeah, I think what we're hearing is less is more when we're talking about estrogen and for specifically vasomotor symptoms. I'm so happy that you mentioned the IUD, the progesterone. IUD is a miracle worker for the patients that I'm seeing that are really dealing with really heavy bleeding and all of those different symptoms. When we see these perimenopausal women, not only are they, they're hemorrhaging, and they're trying to work and take care of older parents and, kids that are, in middle school or in a gazillion activities. But they're also navigating, many times what we'll see is their cholesterol starts to really go out of whack. And we start to see patterns in that where they're high density lipoproteins, those are the happy, good cholesterol that we want high, start to go lower. And then the LDL, which is the lousy bad cholesterol, which we want low, it starts to kind of trickle upwards. And so do triglycerides. And that's kind of the opposite pattern that we really want to see when it comes to cholesterol and cholesterol metabolism. And all of these pulsatile hormones affect cholesterol, which is also happens to be a pulsatile hormone. So no wonder we feel just not good some days. And then our blood pressure is also trickling up as all of that is happening.
Yes, I think as we get in our perimenopausal years, our family genetics begin to sneak up on us in faster or less fast steps. And we do need to take that into consideration. But I think the IUD has been wonderful for patients. And I agree with you. Back when I was training, we gave people an average dose of menopausal hormone therapy, but now we really want to start at the bottom and work up.
Now that patient, that amazing patient that shared her story, if she was completely asymptomatic, meaning she was having no symptoms above her waist, she could, walk, she could skip up 2 flights of stairs. She could carry, 2 bags of groceries from the car, into the house without feeling short of breath. Or my favorite symptom for women, excessive fatigue. I mean, what woman does not have excessive fatigue? But if she's not, or chest pressure, heaviness, tightness, if she's not having any of these things and she's having, active vasomotor symptoms, and then it sounded like she had VT and those things first. If for that person in particular, screening her would really be essential to see if she has atherosclerosis. And so a coronary calcium score is what we order for women who are completely asymptomatic. And I pair it up with a lipoprotein A or an LPA. It's a genetic marker. We know that if you've got a 0 coronary calcium score and then you've got a nice low LPA, that's good news for us on an atherosclerosis or a plaque high cholesterol, aspect of things. So it sounds to me like she has both, both the blood clotting issue as well as the cholesterol plaque issue. And they both have to be addressed separately.
Yes, so many women think their gynecologist is going to be their only primary care physician for life. And as they get older, I explain to them they need a team looking after them, not just me.
I know, and it's very interesting that estrogen can be a double-edged sword in premenopausal women with regard to preserving high HDL and low LDL. But when you get pregnant or you use exogenous, oral contraceptives, you change the natural anticoagulant levels and develop a prothrombotic state. As people age, no matter what, you have an increased baseline inflammatory state, so your risk goes up for thrombosis. But it's the lack of estrogen that can lead to what Margot's discussing, the cardiovascular effects of lack of estrogen that start to manifest and lead to MI and stuff like that. And it's interesting, again, the genetic background for both VTE and atherosclerotic cardiovascular disease are 2 different aspects of someone's family history, so you need to get both of those.
Mm-hmm. We also, so I think what you're hearing from us for those of you attending is that your family history is really important to make sure that it's up to date. And most doctors' offices have an electronic medical record. Hopefully it's communicating across all of your providers. And what's also very important is if you've had children, is that we make sure that we get down whether or not you've had something called an adverse pregnancy outcome. So you've had a baby too early, or you've had a small baby, or you've had high blood pressure while you were pregnant, or you developed preeclampsia, which is when you have high blood pressure and we excrete these really bad proteins that kind of start to shut everything down if the baby is not, and the uterus isn't taken out rather quickly. It's a rather urgent situation. So what we know is that these women go on to have a 2 to 8-fold risk of heart disease later in life, and they tend to be women who have blood clots, and they tend to be women who have heart attacks. So we don't know that full story yet, but we definitely know that there's associations with it. And, you know, essentially 87% of all US women childbear. So that is our first free physiologic stress test, is having children. So if you can get through, you know, 39, 40 weeks and not have one of those bad things happen, then you kind of passed your stress test, which is really good. If one of those things happen, then finding yourself a good primary care doctor. To Dr. Bacon's, you know, she was looking for collaborators, and so finding a good primary care doctor and a good preventive cardiologist, I think, is really essential to the team.
So when you're bringing more people into your care team, which I absolutely super important, one question that we got is, what happens when your doctors disagree on the best path forward for you, you know, in regards to estrogen and your, I understand a lot of this is dependent on the patient's medical history, but how do you suggest navigating when clinicians disagree on the best course of treatment?
I'm going to jump in first, okay? Because as the hematologist, I end up getting stuck in that middle position, okay? And I think it's very important for people to recognize where people are coming from and what their training has been and what their practice is. So Janice, as an OBGYN, is very familiar with the hormonal risks and the pluses and minuses of estrogen, progesterone, the progesterone-coated or levonorgestrel IUD. I see women who have been told by their local GYNs, even in the last year, 2 years, 3 years, that any hormonal IUD is bad and that they shouldn't take, you know, the levonorgestrel or the IUD. So I think it's hard as a patient to navigate that. And as I view it as our job, and that's why this webinar is important for patients, but also for clinicians, to educate people, you know. So I see 22-year-olds again, because I see, you know, those prothrombotic women who's had a DVT, but they may have heavy menstrual bleeding on anticoagulation, and they have a copper IUD placed because their OB thinks that hormonal treatment is bad. So I sometimes carefully walk around why they were told that this was the choice for them. You need to make sure you encompass and embrace their entire history, and often I'll discuss with the other provider. But the patient has to let me know that somebody in their care team said, hey, you shouldn't do this, and this person said do that, and I'm like, well, let's get to the bottom of this. And then we can talk about shared decision making with patients and assessing the benefits and risks, because it's not always black and white. And so some patients may prefer the benefits of something and are less concerned about the risks, yet a different patient with the same profile may be more worried about the risks than the benefits. So that's how the hematologist here approaches it. But I'd love to hear, Janice and Margot, how you approach those differences.
You know, what you said is such an important point. And I have just had to be brave at times and say, and thankfully through the medical record, we can do in-basket messages and things like that, and just said, could you tell me what you're thinking about for this patient? Because this is what I'm talking with her about. And I will say that thankfully at one of our hospitals, the hematologists have gotten together and had a discussion about the use of vaginal estrogen products for their patients with histories of clotting disorders, and agreed that for most patients, they will not be prohibitive for a metered amount of estrogen, whether it's just a topical bit at the introitus or whether it's a tablet or a dose of cream twice a week. And I realize that we don't mean to put you in the middle, but you're right. If we give the patient something and they have another clot, you're the ones that have to help bail them out. So I think that keeping the chain of communication open is really good. Even, and if you don't want to do it in the chart, call them up and be brave. Yeah.
I think being brave is important, and I think, you know, we're all of us in our practices so busy that you don't often feel like you have the time, but that's the best care for the patient. And so I think if patients who are listening feel that they are getting conflicting advice and different opinions, and one is saying absolutely no and the other is saying absolutely yes, then I think you need to get them to speak to each other and go from there. Yes. And sometimes that's why there are second opinions, depending on the, you know, patient's the provider's background. But it is a hard thing to navigate because when we get to some more so oral estradiol or transdermal, and I see there are a lot of questions about this in the chat, the physician's perception of risk may differ from the patient's perception of risk, and that, I think, is something that we all as providers need to recognize and discuss.
Yeah, I think that's very important. I also think for those of us that work at large academic medical centers, we oftentimes will get pulled in. I know within our Women's Heart Center, I watch our team get pulled in for third, fourth, seventh, consult, depending on what's going on. And when I see our team really make the biggest difference is discerning the why did it happen, like getting down to what we say are the mechanisms. It's like, what actually caused this to happen? And then if we can tease out why someone had, an event occur, then I feel it's easier for the rest of the physicians to get in alignment, because then you can kind of pull out national guidelines and, you can use that as your North Star. I think when it gets really hard is if, you have somebody who's higher risk, who maybe hasn't had an event, or isn't deemed in one of these highest risk categories, and they have a lot of vasomotor symptoms and they're just miserable and their quality of life is just awful. And then they're trying to navigate. And I'm in LA, so I see patients, and they've got bullets in their gluteus maximus, they've got creams all over. It's sometimes really, it really can be just way too much. Like I said, less is more. It's really about your symptoms and how you feel. And then you have others that are just completely on the other side. And so I think being able to navigate or find somebody who is a hormone specialist, who is a gynecologist who really has a subspecialty in this space, I think is really great for those vasomotor symptoms.
And I think it's hard to, even in academic centers where the data are not the best in the world, right? So like if we look at statins, or DOACs, we have trials of one drug with 18,000 patients, right? We don't have that for data for menopause treatments and hormone treatments in women, except when we go back to the women's health studies back that was published, I guess like 20 years ago now, right? Where there was a large study of tens of thousands of women randomized to estrogen, progestin, or not. And again, different formulations of estrogen than we have today. And it was found that giving estrogen when women reached menopause did not confer any cardiac advantages or bone density, prevention of osteoporosis. and was associated at the time with some concerns for increased risks of cancers. And I think that really put the damper on the use of hormone replacement therapy in women. And, you know, we could quibble about, you know, there was no difference in mortality in that study, right? So women had events, but they didn't die. But again, it was a, you know, not a long duration. But I think we need to re-examine that study, and we need to use updated hormones, as everybody's been saying, at the lowest possible dose to control symptoms. And I think that's also the shift that we've been discussing, is symptom control and not necessarily cardiovascular risk protection or osteoporosis protection.
That's a very key message that you just said, Jean, is that, you know, we do not use hormones for heart health prevention. That's a really important message. You know, whether you're younger or you're older, we do not. So we have so many other things that are good for us to do, or a handful of things to avoid, like smoking, for example. We talked about, you know, women age and, you know, oral estrogen. Well, if you throw smoking in there, then, you know, you're really high risk. So maybe you're someone who's, you know, listening today, and you had a blood clot, but maybe these were some modifiable, you know, things that were happening, and it may not be that you have a genetic, you know, propensity for it, but it just so happened that your age, the dose of the estrogen that you were on, and maybe then you were smoking. And we really don't know about, you know, vaping or you know, marijuana or other types of, you know, social you know, and smoking, and really anything just seems not to be good.
Yeah, I think that is very important. And asking the patient what is the main thing that they're worried about and what is the main symptom they would like to have relieved. And I also think reassuring them that what they might need in these years transitioning to menopause may not be the same combination and the same dose that they might need 10 years later. And reassuring them that if they pick something now, they get to pick something else if what you're trying is not satisfactory. So that the women who are transitioning, who might have risk but have not had an event, may be able to pick something different than Christine, who's had an event, or may be able to pick something different than women who have a genetic risk that's not going to change, but maybe only increase with age. So I think that talking to women about what's appropriate now and what we're going to manage for the future is really different. And the other thing that's new is we don't have as much data on some of the newer products, such as the newer progesterone, drospirenone. That's not available as a menopause therapy, but drospirenone as a pill alone may have some benefits in the perimenopausal group who have not yet experienced event. So we've got a much bigger smorgasbord than we had previously, but we have to sort of prioritize our symptoms and prioritize our risks.
So Margo, were you going to say something?
Just one last thing, just to piggyback on what Janice was saying, is that, and I'm looking in the chat here at a couple questions, and there are a lot of things that you can do that are anti-inflammatory, which I kind of think helps everything. So like Mediterranean style nutrition is a great way of eating that helps for both heart health and cancer prevention. There are certain things that I know that you can avoid, and I'll leave that to your OB to kind of tell you, but there are a lot of things that you can do, like and different bedtime behaviors, and many different things that we can do outside of medications that can help us be more comfortable. Whether that's, you know, trying to relieve, you know, hot flashes at night, or or vaginal dryness. There's a lot of things out there, but from a heart health standpoint, I think trying to be as anti-inflammatory as possible with things that we are ingesting is just really a win-win situation kind of across the board. I think it doesn't matter which specialist that you speak to.
Yes. And looking at the chat questions too, so that we don't run out of time. Certainly, again, I want to say that many of the hormonal vaginal estrogen preparations are not systemic. There are some preparations, such as a ring which goes in the vagina, that can produce a systemic estrogen level versus a ring that does not produce a systemic estrogen level. And so that's important to understand what is being prescribed. But in general, the transdermal estradiol preparations would be overall less worrisome. If you had to lump them all together into a category, would be less worrisome for some of the cardiovascular and thrombogenic events compared to the oral therapies. And I think one of the hardest is if women need something for symptoms and they don't have enough coverage to be able to afford some of the therapies that might be your first choice. And that would be a topic for a whole different webinar. But I think the transdermal estradiol would be more preferable to that than the oral therapies.
Yeah, no, I think you bring up a good point, and I want to just keep reiterating that it is the estradiol, it's the transdermal estradiol, it's not the contraceptive patch, it's not any contraceptive pills, right? Taking your daughter's birth control pills is the biggest risk. And when we look at the gradient of risk for thrombosis, it starts up there with the high dose estrogen and progesterone and works its way down. And the very, very low risk are the estradiol formulations. The oral does have a slight increased risk over the transdermal because of the way they're metabolized. And the oral, you have to swallow the pill and then it goes and gets into your liver and gets metabolized. And that seems to affect some of the coagulation factors more than the transdermal, where it goes right into the skin and there may be some skin metabolism. And so if you can tolerate the transdermal patch, it sounds like we all agree that that may have the lowest risk for thrombosis associated with it. Now, there are great questions in the chat.
I was gonna say, yeah, I was gonna dive in, but go right ahead, Jean, if you see some that really pique your interest.
Well, yeah, no, and I think there's some themes, and so I'll just talk about the history of venous thrombosis, right? And this is where the benefit risk analysis and your personal preferences and concerns really make a difference when you discuss the use of hormone replacement therapy, estradiol, and its impact on your health. Because if you're not sleeping from hot flashes and you've tried other approaches, lifestyle, either increasing exercising, changing diet, don't drink alcohol before bedtime. All of these things may affect your risk for getting hot flashes. But then it's worth discussing your particular risk. There are some data from Europe that suggests that even women with heterozygous factor V Leiden can take the estradiol formulation in the transdermal patch and not have an increased risk of thrombosis. We know that even with the previous, equine estrogens, the Premarin and Provera regimens from, I don't know, back when I was in medical school, which was longer ago than I care to admit, that there's a difference now in terms of risk than previously, and so I think we would discuss. There are some women who have such severe symptoms that even if there is a risk of thrombosis, we carefully monitor them. We know, again, from the Premarin Provera that the risk is highest in like the first 1 to 3 months, and then it really trails off. So if you've made it past a year, you don't need to worry as much about your risk. But to one of the questions there, I will say, again, severe symptoms, I will use some anticoagulation in these women to, if they've got factors that put them at increased risk for recurrence, like residual vein thrombosis, a strong inherited thrombophilia like homozygous factor V Leiden, antithrombin deficiency, protein S, protein C. But it is a very individualized decision. And for many of these questions that are in the chat, there are not guideline level data to tell most clinicians what to do.
And one thing, when even for physicians looking through the data, comparing people that are put in trials, which are so randomized control trials usually have a definitive end, whereas observational trials can go on longer. So trying to weigh the benefits and then look at your patient population and see if they compare to those that were in the trials often is like walking through a labyrinth as well.
Exactly. Yeah, no, I mean, this is, I think, Jill Biden actually had sparked a campaign for increased NIH funding for Women's Health Initiative and in further investigations and research into conditions that specifically affect women. And I think this is an area that we clearly need so much more really good quality data on.
Mm-hmm. Okay. I'm just looking at the new questions that have come in. So here's a question regarding obesity, and it's a known risk factor for thrombosis. Does it have the same synergistic effect for hormone therapy? So is that a risk factor for starting hormone therapy?
So I would say that everybody has a slightly different threshold for what pushes them over the edge to cause a thrombosis. And we know that risk factors are additive. We know with oral contraceptive type estrogen, progesterone, that actually some things are synergistic, so that they actually escalate your risk more than just an additive effect. But the more risk factors you have, the easier it is for you to get a clot. And so obesity is a factor. I mean, when we look, we're talking like BMI over 35, some would say BMI over 30. The odds ratio for getting a VTE is about 2.3. So that is a standalone. You've got a 2 to 2.5 times higher risk if you're in that BMI category compared to someone who's in the normal category. That risk is the same as if you have heterozygous prothrombin gene mutation. Exact same, 2.5-fold risk. So they do add up, and it's a factor. And if you can control it, and I've actually, over the last year, have advocated for people with BMIs of 40 to actually try one of these new, initially designed for cardiovascular health and diabetes control, but the SGLT inhibitors, because they do make a difference.
Okay. And we also got a question I saw come in. We've talked a lot about treatments, but it was specific to bioidentical hormones and the safety of these. So Dr. Bacon, I don't know, or Jean, if you guys have any thoughts, Margo?
I'm happy to start out with that too, because that is a topic that has been looked at, or a review of the literature has been looked at by the American College of Obstetricians and Gynecologists, and also addressed by the North American Menopause Society. And so I will tell you first, a pro that many patients will say is that they can have a compound made for them that doesn't always exist commercially. They can have things within that compound tweaked to levels that are not available commercially, and they can have things added such as adrenal hormones that are not available to commercial products. So that is a pro that patients will state. But now let me give you the con, and that is that if you might not be able to tell if you're getting them from pharmacies who do internal controls to assure that every batch is the same. You may not be getting them from pharmacies who are comfortable with the data that we've been talking about. They use salivary levels for hormones, whereas we use blood levels. There's not an ability at this point in time to actually biopsy the tissue and say, are we reaching the level that is interesting to the patient as far as treating things like vaginal dryness. So at the present time, because compounded therapy is in the category of a supplement and is not as rigorously tested as commercial pharmaceutical preparations, it is not recommended as an equivalent substitute, and it definitely is not recommended as an equivalent safety to pharmaceutical preparations that are available. That being said, I have some patients who really want to use those, but I will more strongly warn against those for patients who are in high risk categories.
No, I tend to agree with that, Janice. I think that if something's going to work, we're going to have good data to show that it works. Like look at just totally tangentially, but look at 15 years ago or so, soy was thought to be bad for women with breast cancer because of the natural estrogens in there. Now that thinking has flipped, and it's because they're not potent enough. So I think that while eating healthily and taking known supplements can be helpful, you're not going to get the same effects from prescribed as you would from prescribed medications.
So we've got just about 3 minutes left. But I did put a link to the survey in the chat. So if the attendees could just take a few seconds to answer that, we'd really appreciate it. In closing, I was going to go around and ask each of our hosts this evening to just any words of wisdom they have for a woman navigating, this point in their life in regards to, menopause, but also, most likely with the history of thrombosis in some form or another. So, Margot, I will start with you.
Well, I would say that, making sure that you're taking a full look at yourself, especially if you're going into that perimenopause or early menopause stage, specifically knowing what your LDL cholesterol is. You want it, probably hanging around 70 if you've had a VTE before, and, making sure that, you're really watching over carefully your blood pressure. I think those are the two biggies is, on my end, if you're trying to look at your whole self, and you're looking for prevention, and of course, Mediterranean style nutrition, I think is always a wonderful option. And thank you for having me today. This is really fun.
Absolutely. Janice.
So I would say for our patients, particularly at risk, try to bring to your gynecologist the most information you have about your risk factors. It's our job to look at your other risk factors too, like is diabetes a risk factor? Do we need to be bold and say, what can we do to help you with your weight, as Jean mentioned, because that can lead to increasing inflammatory states. And try to be open about different methods of hormone therapy, such as the IUD. And lastly, talk to the gynecologist. Maybe you do need to discuss even something permanent. Do you need a hysterectomy if you are going to need to be in perimenopause and you require full anticoagulation and other things haven't worked? I mean, I know we're talking about hormone therapy, but I don't want to throw out the option for permanent therapy for some women, because that perimenopausal time is really hard to control the hormones when you must be on anticoagulation.
I know that's a great point. And there are a lot of other ways to address it, both surgically and other treatments. Catherine, thank you for having us. Thank you for hosting this. I'm delighted to be here. I want to echo what both Janice and Margot said about, you know, yes, you're going through menopause, don't neglect the rest of you and make sure that you get a team. I mean, here we have 3 different providers, right, with different perspectives. We will all work for you to, you know, find the best treatment for you, the individual patient, and look for providers that have those skills.
Absolutely. Well, thank you all so much. This was such a really knowledgeable, enlightening, fun hour. So I really appreciate you all taking the time. And of course, to our attendees for participating and sharing your wonderful questions. I hope we got to, I think we did a pretty good job getting to most of them. So thank you guys again for your time. And I hope everyone has a wonderful evening.
Thank you for asking us. I enjoyed visiting with all of our participants too, and I hope we did answer a lot of the webinar attendees' questions.
Absolutely. Terrific. All right. Good night, everyone.
Night. Thank you
Good
very
night.
much.
Bye-bye.